So, just to give you a very brief outline of the way the session will run today, we will start with a talk from Professor Simon Carley, and then we will go into a second half, which will be interview practice questions. So, without further ado, I'll hand it over to you, Professor.
Yep. Thanks for inviting me along. My name's Simon. It's what my mum called me. We'll go with that. I'm Dean of the College of Archem. I work up in the Northwest. I'm an emergency physician by day. I also work with the PHEM service up here. We'll talk about all this as we go along and various other bits and pieces. One of the great things about my job is we're allowed to do lots of different things, which is one of the great advantages of working in emergency medicine. But there you go. That's a talk for another day.
I'm on a Zoom meeting. Yeah, I'm on a Zoom meeting.
Okay. Yeah, definitely on a Zoom meeting. So no problems at all. I put a thing in the chat, so if people want to ask questions as they go along, that's fine. And we'll try and get to those, and we'll try and keep on time. So the talk was originally called Stepping Outside, because most of our lives as doctors we spend in hospital. But this is more about what happens when you go into the pre-hospital environment, particularly talking around pre-hospital emergency medicine, or PHEM, as we sometimes call it, PHEM. And how that functions here in the Northwest, and a little bit about how it works in careers, but also why bother and all that kind of stuff. So it's a really fantastic thing to do. I love it absolutely. But these are the sort of things that we're going to cover: the training pathways, PHEM as it exists in the Northwest, but it's probably fairly similar to how it exists across the country. Not only too much about simulation, but we do a lot of it in some really high fidelity simulation. What it means by excellence and the importance of culture and how we get those things to work for the benefit of the patients and having a great time. So background is, for me, I said I'm an emergency physician. I work up here in Manchester. And from a training perspective, to talk about that, if you want to work in PHEM, which is the sort of the pre-hospital side of things, you need to be trained in it, to be honest. The days of old, which is that you could be an enthusiastic amateur and just sign up with an air ambulance or go and work in the pre-hospital environment with the ambulance service, are really starting to disappear now. And it's become much more structured in recent years, and it's now a subspecialty in its own right. So you can enter PHEM training, if you're thinking about this for the future, through this sort of pathway. You go through, obviously, a medical school, which is 5 years or 6 years or 4 years, depending where you are in the country. Then you do foundation training, and then you'll do your specialty training. For emergency medicine, that's 6 years. But it could be intensive care medicine or it could be anesthetics. Those are the three major routes in. There's a couple of other little ones, but those are the three major routes in. And ordinarily, that would bring you out as a consultant in your chosen specialty. If you want to do a subspecialty in these, what you need to do is an extra years with the training. So you compete nationally for something called the IBT PHEM program, and then you do at least a year with an air ambulance to do subspecialty training. So it extends your training by about a year, and it's pretty hard work actually, and incredibly competitive to get into. There's only about 30 jobs per year, and there's only a relatively small number of air ambulances around the country. Now, there are other options to get into pre-hospital care, which we'll talk about as we go along, but the official training program is this one. And where does pre-hospital emergency medicine sit? Well, it sits in the pathway of trying to find those patients who really need advanced level care before they get to hospital. So this is the sort of the global look about how emergency medicine or how emergency care works. So you get access to whatever. Most of the patients that we see are not going to self-present. They're going to be patients who have been notified through the ambulance service. So there on the left-hand side, the primary PHEM care and transfer. That's going out to people at the scene of their accident, their assault, their cardiac arrest, their fall off a building or whatever, anything like that. There's the orange box on the left there. There's also the orange box at the bottom, which is what we call secondary PHEM, which is where you do transportation, or we often referred to in the UK as retrieval. So that aspect is more the case you see a lot in places like Wales or in places like Scotland, where you may be going to your local unit, which is geographically a long way away from your cardiac arrest centre or your major trauma centre, and those patients need to be retrieved back to the specialist services. So where you are in the country depends on where you do a mix of those two things. So where I'm in the Northwest, we do very little secondary care. We do some, but not a lot. If you go out and work in Australia, then quite a lot of it is secondary care. That's secondary PHEM transfer, a lot of retrieval type work out there. And in the UK, as I say, Scotland and Wales do a bit of a mix. So it depends a little bit where you are. And in part of a training program, you need to be able to do both, really. So that's how that fits together. And it's really interesting. It is, to be honest, it's the more exciting end of emergency care because it's the group of patients who are incredibly sick or very, very badly injured, where they really do need the sort of interventions that we as doctors and critical care paramedics and some critical care nurses can deliver. So it's the really exciting stuff. And it's, to be honest, in the day and age, it's a bit of a break from what you've probably seen in the press about the difficulties that we have within emergency care in general. So my department may well look like this. In fact, my department's actually pretty good, but there are departments around the Northwest and certainly around the country where emergency care is pretty tough gig at the moment. And sometimes it feels as if you can't do the best job in the world here. But when you work in a pre-hospital service, you've got a small number of very highly motivated, very interested people with really sick patients who can potentially really benefit from what you do. So from a personal perspective, it's very rewarding and it's really good fun. Fun's probably not the right word because these people are suffering, but it's sometimes the sort of thing that you think this is why I went into medicine to try and do to save lives and to do good things for people. Doesn't always work. Not everybody survives. We go some bad outcomes, but there you go. But that's kind of the background. That's the training program and why we do it. So tell you a little bit more about the Northwest, give you an example of what PHEM career would be in the Northwest. So I work as an emergency physician most of the time. I work part-time with these guys, Northwest Air Ambulance Service. This is the helipad on top of Manchester Royal Infirmary, which is where I work. Nice, bright, sunny day. I think they've just watered it. It makes it look really cool. And it is a really good, fun job. I do this a day a week. And this is a really positive thing. So Northwest Air Ambulance, typical of other air ambulances, is a charity. None of this is funded by the NHS. It's a separate contract that I do, or you can do other ways, but I do it as a separate contract. And I work with these people in this aircraft with a great, fantastic team. And we cover the northwest of England. It's about 7 million people, 14, nearly 15,000 square kilometres. And our service has so just take that in mind. Just remember that 7 million people, 7 million people. And to cover that area on the PHEM service, we have 3 aircraft. This is the Eurocopter 135, 2.5 million, 160 mile an hour. Fantastic bit of kit, the most common aircraft used internationally for air ambulance work. And we have 3 aircraft. 2 of those aircraft are actually staffed by critical care paramedics. There's only 1 aircraft which has a doctor on it. So it's 1 doctor for 7 million people. We do over 3,000 missions a year, and we now work 8 till 2 o'clock in the morning, 7 days a week. That slide's a bit out of date. So it's really good fun from that point of view. But think about those numbers and you've got a very, very small resource that you're trying to target at that very, very rare case that where we can add benefit and we can add a bonus to. So those are things like major trauma, but not just all major trauma, but major trauma that might need something like an anesthetic at the roadside. They might need a surgical procedure like a thoracotomy where we open the chest for a stab wound to repair injuries to the heart. Or we might need to do an emergency cesarean section for somebody who's at the point of death of the mother's dying. We will take the baby out at scene and try and resuscitate the baby and the mother. Or they might need an amputation because they've got their arm or their leg caught in machinery and they need to get to the hospital quickly. So really high level stuff. And as I say, we'll do quite a lot of missions. I've been out today a couple of times, done multiple stabbing and got tasked to a pediatric cardiac arrest. That's the kind of cases that we deal with. So not run-of-the-mill things. Quite distressing sometimes, quite emotionally engaging. But we have a great team to support us with that psychology, psychiatry type thing. But that gives you an idea of what we're doing. In addition, we're talking about PHEM, not necessarily as a career, but quite a lot of us also volunteer in our free time, and we respond from home. So this is part of what's called a basic scheme, which is the British Association of Immediate Care Schemes. And this is a series of people who are volunteers who respond from home. This is my car. It's got lights. It's got sirens on it. And I will respond from the ambulance service who might send me a text through on my phone as they did this morning. Or I might get alerted by other means. We'll go to the scene and we'll support either the PHEMS crew if they're there, or if the PHEMS aren't available, we'll go and support the ambulance service as it is. And that's costs quite a lot of money to do. Again, entirely charity based. And for this job, for the PHEMS job, for the pre-hospital charity, the car, I did 100 jobs with them last year. So I 1 job every 3 days. And again, it's the same sort of patients, high level, severely injured, cardiac arrests in young people, pediatric cardiac arrests, major obstetrics and gynecology. And this is the sort of stuff we carry in the car. It's similar to what we carry in the aircraft. And all of this, yeah, charity based. And yeah, that's us across things. So what is it that we offer? Because the ambulance service is pretty good. In the northwest of England, like many places now, you've got a various different grades of paramedics. So you've got the EMTs, the emergency medical technicians, then you've got the paramedics themselves, then senior paramedics, you have duty commanders, and then you have the advanced paramedic practitioners here. Sometimes those are called critical care paramedics, sometimes they're called advanced practitioners, those kind of things. So, and they're pretty good. They'll deal with things like traumatic cardiac arrest, they'll deal with serious cardiac arrests, they'll deal with pediatric problems and stuff like that. But they don't necessarily have the scope of practice that we have as a doctor. So what do we provide, which the normal ambulance service doesn't? Where can we add value? And it's this. So PHEM is pre-hospital emergency anesthesia. So if you have a serious head injury or you've got a serious chest injury and you can't breathe, then one of the things we can do in hospital is we can take over the breathing for you. We can manage your oxygen levels, your carbon dioxide levels. We can manage the pressure that's driving the blood to your brain, the pressure that's coming out. We can do all of those things in hospital. And it's really been shown that makes a difference to outcome. But why wait an hour until you get to hospital? It's much better if we can do it at the scene. And we've got evidence now that that improves outcome for our patients. We give blood. So we carry 8 units of blood to the scene on the aircraft. So that's 4 units of plasma and 4 units of blood, packed red cells. And we can give that to people who are bleeding out. We've got loads of drugs which we can give. We give all the emergency drugs that I would give in the hospital, in the emergency room, the resuscitation drugs, I can give at the scene. And the surgical procedures. So as I said, opening the chest, doing a surgical airway. So if the face has been bashed in, we can put the breathing tubes directly into the neck. We can do amputations. We can do a whole variety of different things. But more than that, there's the thing that most of the allied health professionals, so physios, nurses, paramedics, ACPs, etc., they have to follow protocols. So it says, if this happens, do this. And that's how most allied health professionals work. As doctors, we can do what we think is right. And so we can deal with difficult decisions where it's marginal, or we can change the protocol because it's the right thing to do. So I'll give you an example. I went to a chap who had a cardiac arrest in parts of Cheshire. And we did his ECG. We managed to get his heart going again. We did his ECG, the electrocardiogram, the wavy lines, and all that kind of stuff. And it did not show that he'd had a heart attack. So the rules are he should just go to his local hospital. But what we could do is we could say, well, actually, this is a 45-year-old guy who's just collapsed whilst running. He needs to go to a centre that can do the specialist procedures to work out what went on and to put an implantable defibrillator in to stop him having it again. So we flew him direct. It's a very small example. It gives you an idea of what we can do and what we can offer is dealing with complexity, difficult decisions, judgment, diagnostics. Another one, I went to a major incident last week. It was in the papers, so I'm not telling you anything you don't know, but a car went into a whole bunch of running club. There were 11 casualties, 3 were major traumas, very seriously unwell. We're stuck in the back end of Cheshire. We're an hour away from any major trauma centre. And you've got 7 casualties, and you have to decide which patient goes to which hospital based on limited information. And that's the kind of decision which is difficult to do in the middle of the night when it's dark and it's raining and there's only you there. But that's where we offer value. So lots of things that we as clinicians can do. And yeah, this is the basics team. This is our basics car. I get to drive this. I've got a blue light license. It's an amazing beast of a machine. It goes quite quickly. Say no more. And we have an amazing team. One of the great things about working in PHEM is because it's really difficult to get into. People are really motivated. So this is me. That's Dave, our pilot on 72, the aircraft I fly on. He's a great guy, hugely experienced, fantastic, helps us with loads of different things, gets us to where we need to be. And then you've got Adam and Rob, critical care paramedics. These are paramedics who have got huge amounts of training. So even when they're top of their game with their ambulance service, they then come into HEMS. It then takes them about another year to get their extra HEMS training to learn all the additional skills that they need. So it's an amazingly fantastic group of people. So how do we hear about jobs? That's quite an interesting question, I think, because it's probably the hardest question we've got in the entirety of pre-hospital medicine is which jobs do you go to? 7 million people, 15,000 square kilometers, huge numbers of people coming into the ambulance service. So how do you find out? Well, what we have within the system, and again, you have to learn about all of these things as you train, is that within the ambulance service, we have one of our critical care paramedics who looks at every single job that comes in that flags up as potentially high risk and decides whether to dispatch us. But also, the ambulance service may arrive at scene anyway, and they might just go there and go, "Oh, actually, this is a lot worse than we thought," and they'll call us to come in as well. That happened a couple of days to me, a couple of days ago to me. And we also have pages on my phone. So on my phone, um, with if any job within a 20-kilometer radius of where I am scores on a high level, when it gets coded, when it goes into the ambulance service, they code all the things, they give them a DX number. If it comes up with a high risk DX number, so DX0101 is a cardiac arrest code. So if that comes up, it pages to my phone and it tells me that there's a job within 20K, and then I can choose to phone up and potentially go for that as well. But finding those jobs is real needle in the haystack stuff, because not every job that you go to initially you needed, quite a few of them you're not. And then there's also the risk that you might have missed something along the way. So what sort of things are we going out to? We mentioned it a little bit. But a typical case may be something like this. So male, 12-year-old, hit by a car, significant injuries. Those numbers there, I wouldn't expect you to know now, but respiratory rate 29, so the breathing at 30, nearly 30 breaths a minute, that's high. The heart rate's 120, that's high. The blood pressure 90/60. For a 12-year-old, still a bit on the low side. SaO2 is how much the percentage of the blood which is saturated with oxygen. That should be 100. It's not. And GCS is a measure of how awake somebody is. It's a score out of 15, so 7 is low. So this is probably somebody who's got a significant head injury, they've got a significant chest injury. And this is the sort of person who needs immediate management. So they may need, as I said before, they may need an anesthetic. We may need to open the chest to relieve any additional pressure from a collapsed lung in the chest. Obviously, you've got to give people sedation or an anesthetic before you do that, because they don't really like having their chest opened whilst they're awake. You need to give them antibiotics. You need to give them blood products potentially. And if this happened 40, 50 minutes away from a major trauma centre, which is not uncommon, that patient may well die before they get to the hospital unless you intervene early. So that's the kind of typical sort of thing that we would do. Lots and lots of different interventions. So yeah, RSI, that's the fear, putting them to sleep. Thoracostomy, that's making holes in either side of the chest, surgical procedure. Intraosseous access, so that's we drill into the bone. If it's difficult to find a vein, we actually put a drill into the bone. You can infuse fluids directly into the bone. Central access is putting drips, not just into the arms, so that not putting cannulas just into the arms, but actually going to the central veins in the chest. So techniques to do that. Blood products, packaging them up, and then different drugs, stunting them, and all against the clock. Well, we try and do this within 20, 30 minutes of arriving on scene. So lots of pressure, lots of things to do. Other things that we might go to that you may have seen, we might go to big incidents like big RTCs, road traffic collisions, deal with patients there. This is in London. And this is actually me there on the left-hand side in the basics kit. This was the synagogue attack in North Manchester, one of the major incidents I've been to this year, which is a pretty awful event. And the other stuff, so that's the trauma side. The other stuff that we see a lot of is cardiac arrest type things. And we're really trying to push the boundaries of what we do with cardiac arrest. So this would be typical. So somewhere up in the Peak District, somebody has a cardiac arrest there. They might be getting CPR in progress, a young person, previously fit and healthy. They've gone out the day to go walk in the hills. They fall over. They're miles away from a road. They're miles away from wherever. And we can go, we can see the patient, and we can do some really interesting things there. Again, we can take over their ventilation, take over the breathing. We can refine how the CPR is being done. I'm sure you've all trained in how to do CPR. There's subtle things that we can do to make it even more effective. And we can put in lines, so put cannulas and wires into the major blood vessels in the groin and put them up into the chest. We can measure the pressure of when you're doing the CPR, whether it's actually effective, and change all of those things around and try and really refine and do the sort of resuscitation, which is just not following an algorithm. It's just not going, do this, do this, do this. But it's like, do this. Did it work? How did you measure it? How are you going to refine it? What can you adjust? So lots and lots of things that we can do. And we've had some fantastic outcomes by doing this kind of thing. So really quite remarkable stuff. And really it allows you to practice on the cutting edge of evidence. Because it's a small team and because we're a charity, because we do our own thing, you can have the situation where a new piece of research might be published on Monday next week. And if it's really definitive and it really tells us that we can do something different, we can start doing that within days. But when you work in large organizations and hospital trusts and national guidelines, they can take months or years. So we have that ability to be really agile. I love that word. We're really agile about how we manage resuscitation and how we do things. This is me and Mike Southworth up in the Pennines. This is our spare helicopter when ours was in for repair. And this is another one. But yeah, that's up in the middle of nowhere doing resuscitation. So what other things do you need to do if you want to get into this? Well, yeah, you need to learn lots of things. You need to know all the stories about how you treat people with cardiac arrest, how you deal with major trauma, how you deal with really sick kids, how you deal with really severe obstetric emergencies. But that you would expect for anybody who's working in emergency medicine, you would expect to do that. But it's the stuff on top, which really, that's why you need this extra year of training or the extra time. And there's probably three big things there. One is just the environment. It's very, very different trying to even do simple tasks like get a drip in a vein. Getting a drip in a vein in a warm, well-lit, dry, non-confrontational, safe place in a hospital is one thing. Trying to get it into somebody who's trapped in a car upside down whilst it's raining or sleeting and windy and noisy, and there's a drill going on, and there's the fire service are cutting something up about 6 feet away from your ear, and the patient's wet and you're wet and they're cold is an entirely different thing. So getting used to that and being safe in those environments is really important. We do a lot of training. This is a training exercise on the left-hand side, but it's not untypical to what we might do. You also need to know a lot about aviation. So you need to learn about aviation, you need to learn about transport, you need to learn how to work in the roads, how to actually get from A to B safely. Don't kill yourself or anybody else. Believe me, you can kill yourself pretty quickly with a helicopter if you don't know what you're doing. Our paramedics, they do initial 3-month course essentially to learn how to sit in the front and help with navigation and additional communications. And even in the back, where I'm sat in the back, I've got my headphones on here. I may be listening to 5 different radio nets. So I'll be speaking to the people in the aircraft. I'll be listening into at least 2 air traffic controls. I'll be speaking back to ambulance headquarters, and I may have another feed in there as well from people on the ground like mountain rescue. So lots and lots of things to get used to, and a checklist on how to stay safe within the aviation environment. And then lastly, there's what we call halo skills. So halo skills are what are known as high acuity, low occurrence. So it's stuff which you don't do very often, but it's really high stakes stuff. So things like opening somebody's chest at sea. So stab wound to the chest, they've gone into cardiac arrest. We'll open the chest, we'll find the heart, we'll open the pericardium around the heart. If there's a stab wound there, we will repair the stab wound and then we'll try and get the heart going again. That's not something you want to do for the first time ever at sea. You need to practice that and get good at it. So you don't do it very often, but you need to be really slick, really fast, and really skilled at it. So lots of training around what we call halo skills. That's the clinical side, but there's all the other things as well. This is the diagram that they use in the syllabus, but lots of things. So what have we got there? Using pre-hospital equipment, bottom right. Yep, absolutely. You need to know how all the kit works. I'm not just using it in a warm room, but using it in all different environments. Rescue and extrication, we talked a little about. Patient transfer, so transporting somebody a long distance, particularly in the back of a helicopter, you've got no access to them. It's very difficult to do. Emergency preparedness and responses about major incidents, so bombings, mass shootings, vehicle versus large numbers of people, stadium collapse, burns, all of those kind of things. You need to understand how that's going to work, what the system is going to work, how do you fit into it, how do you provide the best care for a large number of casualties, or very specific casualties like radiation casualties, chemical burns, chemical inhalation, radiation, or even biological agents. And we train in all of those. Working in emergency medical systems, yeah, absolutely. We talked all about that. And then the core business, which is actually providing the day-to-day emergency care. So summarised there on the right as well. One thing to do is we love training. We do lots and lots of simulation, lots and lots of training. So this is in our training room at the PHEM base. And when you think about it, is all of these people, I think, are at the top of the game. These are really, really good clinicians who really know what they're doing. But we still test each other. We still train each other. Every month we have a training day where I or one of my colleagues, we get put through the paces. It'll be like doing an OSCE every month. But even when you've been doing this for 30 years, someone is still going to be OSCEing you every month because that's the kind of level that we want to aspire to. And it's how we learn. It's fantastic to be with such a great group of people. We also do a lot of data. Again, we can manage our own data, and we can look at things like blood transfusion. We can look at how we perform, where we go to our cases. Those are the red dots in the middle. What our outcomes are from blood transfusion. This is a while back now, but looking at 344 patients who we gave blood products to at scene. So that's 344 patients who would ordinarily have to wait to get to the hospital before they were given blood products, and many of these will have been life-saving. Lots of research as well, and we've done a whole bunch of studies recently. So Tetris study was looking at the thoracotomy, so looking at those patients where we have to open the chest after penetrating trauma, whether they've been shot or stabbed. Swift was looking at different sorts of blood products to use in the pre-hospital environment, and Paramedic 3 was looking at different ways to give adrenaline during cardiac arrest. So along with the clinical side and the teaching and the education, you've also got the opportunity to do research on a group of patients who previously didn't get a lot of research done on them because it was considered a bit too hard, whereas now we're starting to get that. Careers, I think we talked about already, so we won't go over that one again. And then other things. So just to finish off really, if this is the sort of thing that you're interested in, it is difficult to get into training. It's very competitive. So start thinking early about what you can do. When you're a trainee, when you actually get into medicine, there's things that you can do. So you can go around the world. This is Ollie, one of my colleagues. He went off to Australia, worked with Careflight, I think. I know he worked with Sydney Hems, who are an amazing group of people. I've flown with them a few times. Great service, amazing service, lots of fun, big helicopter, lots of distance. You can do fellowships in the UK, so take a year out from training, what we call an OOP, and do additional training there. You can do observerships. You can apply to do those when you're a doctor. But you do need to apply early, and again, it's a bit competitive. But outside of that, there's lots of other things you can do. I started off with two of these. I started off in the military, so I was in the army for 13 years. That's how I kind of got involved in this. Also did a lot of motorsport medicine, so I was a medical officer. I used to be in the car at the back of the grid chasing around cars. That was a lot of fun. But you can also get involved, even as a medical student or before, with things like St. John's, the Red Cross, CFR, Community First Responders Post. A lot of medical schools are allowing people to do that now, so that's good. And lots of other things as well. So coming to the end, I've probably got 1 minute. Have I got 1 minute to show a video or so?
You can take the time you need. Just don't worry about that.
I think there's a video coming up which we do for what we call the attack course, ATACC. So it gives you a bit of an idea. So I'll play it. There are some real patients here. It's all been taken off the TV, or it's been taken off. Yeah, so I'll play the beginning of it. I'm not sure I'm going to play all of it, but it's taken off the TV or it's been taken off uh, settings where permission has been granted by everybody who's involved in it. So we have consent for the showing of the video.
Yeah, with the opposite, just you reading that check. If the opposite was check.
Oh, just see if I can get that last bit to go. Right. See if we can turn it off. Right. Questions or interview practice. So that was it, really. Is there anybody there?
Perfect. Thank you so much, Professor. That was really, really insightful. Especially in appreciating like all the realities of medicine and especially in being a femme doctor. If anyone has any questions, now is the time to mention it. We do have a couple of minutes for any Q&As before we move on to the breakout rooms for interview practice. If you guys could put it on the chat maybe, or unmute yourself if you're comfortable enough.
If there's none, that's also fine. Is there a good work-life balance? Yeah, really good. And I'll explain why that's confusing. So different things will appeal to different people, okay? But in my job, because emergency medicine and anesthetics and things like that are sessional jobs, so it doesn't matter whether I'm working on a Monday or a Thursday afternoon or a Saturday in the middle of the night. It's all the same job. Compare that to my wife, who's an ophthalmologist. Her Wednesday is her theatre day, so she has to be there every Wednesday. Whereas if I need to do something on a Wednesday, I'll just swap my shift and do something else. Also, when our children were growing up, when our kids were little, um, I could work evenings and weekends. She could work days. So we had a great balance between the two of us. Because I worked a lot of out of hours stuff, it meant I always got to drop the kids off at school, pick them up, go to the sports days, and huge amounts of flexibility. So there's a balance. You can either work Monday to Friday, 9 to 5, but that tends to be very restricted and you have to do it all the time. Or you can have a crazy life like mine, which is all over the place, but that means you've got utter flexibility. You can do pretty much whatever you want, whenever you want. And yeah, it's really flexibility is what gives you great work-life balance. Getting stuck, and that's my opinion. Other people think differently, and they like to go 9 to 5, Monday to Friday. Boring job, don't like it. But there's great. There's no bad jobs in medicine. There's just people in the wrong jobs. I love my job.
I think we have a few more coming in the chat, so I think we could perhaps answer just a couple more before.
Good luck with things. What do you enjoy most about my job? The people. I love working with people who are curious, who are interesting, who want to do the best that they possibly can. We're a very people-based specialty. Emergency medicine, I work with like hundreds of people. I see 100 people every day. It's fantastic. That's what I love. How do you stay calm in a high stress environment? You know what you're doing. Same as you. If you know what you're doing and you're doing a job that you know how to do it, you're calm. If you put yourself in a situation where you've not been trained, you haven't done the work, you haven't put the effort in, and you haven't, practiced, then that'll be stressful. So put the effort in, train yourself, practice, and then it's not stressful. There are times when it does get stressful, it gets a bit dangerous, but yeah, those things. Things abroad, absolutely. I encourage everybody to do at least a year abroad. Lots of PHEM opportunities in Australia, for example, New Zealand. How do you deal with mental health? See lots and lots of traumatic stuff. Yes, we do. We see some horrible things. See lots and lots of absolutely horrendous things. But, and I have spoken to a lot of psychologists about this, and we've even done research on it. If you work with a community of people who you can talk to, you can share cases, and we debrief every single case that we do in PHEM. So we talk about it. And if there's anything particularly gnarly, we formally debrief them on a 2-weekly cycle. So we train for those sort of things. Yeah, and it's being part of a team that deals with this. And the psychologist once told me she thought it's really good that there are people who don't necessarily enjoy this, but find that this is a fulfilling job because, as her name's Esther Murray, but as it happens, but she said, if I get knocked over on the Euston Road tomorrow, I don't want somebody to come up who's trying to save my life to go, ooh, that's a bit nasty. I want someone to arrive who says, this is something I've trained for, this is something we're good at, this is something we can do, and do our very best. Molly's asked if you need to do surgical training. We will train you for the surgical procedures you need in emergency medicine. As it happens, I did 5 years of surgery before I went into emergency medicine. But yes, we can train you within emergency medicine to do it. And in your PHEM training year, if you haven't done these skills before, we will train you. We'll do a whole bunch of halo courses. So you'll learn those amputation, thoracotomy, cardiac surgery type stuff. Do you have to relieve sensitive information to your patients? There's a whole bunch of confidentiality things that we adhere to. There's laws about it. So things like the Road Traffic Act 1978 and also the regulations around shootings and stabbings means that we always reveal that information to the police. In other circumstances, we're bound by GMC confidentiality. There's a whole set of guidelines that you can and cannot do that. Do you get emotionally involved with patients? If so, how do you manage it? I find certain things unpleasant, more unpleasant than others. How do we manage it? We manage it by talking to each other and debriefing and having conversations and supporting each other. Do you develop immunity to the trauma? I don't know whether it's immunity. It matters what we see, and it's important, but we have coping mechanisms. Difference between critical care paramedic and we have a wider range of procedures. We can prescribe a wider range of drugs, and we can go off-piste. So we can do what we think is needed as opposed to just follow the algorithm. How do you prioritize when there's multiple casualties? We have systems to do that. So there are physiological and anatomical scoring systems, and we have bands which you put on to label the patients and manage the whole workflow that goes through that. But again, we train for that. We regularly train for how do you deal with a mass casualty incident or a multiple casualty incident. And is there a different requirements for them than for... Yes. So PHEM is a different set of requirements. That's why it's an extra year of training. And are there many different charities you can work with? Yes, loads. Your answer. I'll probably stop answering questions then. That was a bit of rapid fire. Thank you for those questions. They're all very relevant.